Hey everyone, my name is Dr. Raman Bhakhri. I'm a professor at the Illinois College of Optometry, and I'll be presenting a 2-hour lecture at the next optometries meeting in Phoenix. The lecture is titled Retinal OCT Imaging Biomarkers. Now, the first question you might be thinking to yourself, well, what's a biomarker? So a biomarker is basically on OCT, and it's only visible on OCT. And these biomarkers are basically guides for us, right? They help us guide diagnosis, monitor disease progression, and then predict outcomes. Now, these biomarkers, they can be used in a variety of different diseases, whether it's diabetic, whether it's macular degeneration, an inflammatory disease, an infectious disease. All of these conditions present with certain biomarkers or characteristics or indications on OCT, and that can again help you guide your diagnosis. It can help you guide response to therapy, whether that be with topical pharmaceuticals, whether it be with anti-VEGFs, something of that kind of nature. But again, predictive and prognostic. That's the way I think of biomarkers. So if you can identify these early on, you have a better idea of what it is and what to do going forward.
So what are some of those differences between the diagnostic and the prognostic biomarkers that you'd mentioned earlier?
Sure. So let's get into maybe some specifics. One of the specifics ones would be for diabetes. Now, diabetes we know encompasses quite a bit, whether it's non-proliferative or proliferative. But there's certain things when you do an OCT on a diabetic, if you see it, it should be a cause for concern. So one of the things you want to look for is something called disorganization of the inner retinal layers. That's basically shortened up into a nice little word called drill. So if you see drill, what are you looking for? So again, look at the look at the word itself. So inner retinal layers. Look at those inner retinal layers. If you can see that they look like layers of a cake, you're good. The patient doesn't have drill at that point, and that means their outcome in terms of macular edema going forward is going to be a little bit better. So they'll have a better response to therapy. Let's contrast that with someone who has drill. Look at those inner retinal layers. If you can't make those inner retinal layers out and the patient has macular edema, the outcome for that patient's not going to be as great. They're not going to respond to anti-VEGF as well. So again, their vision might not be recoverable back to what it used to be. Another biomarker you might want to consider in diabetes are called hyperreflective foci. These are really only visible with OCT. You really can't see it with your own two eyes. So if you're doing a 90 exam or a 78 exam of the macula slash fundus, you're not going to be able to see this, right? These usually present with macular edema, but if you see them, they're basically representations of microglial tissue, so inflammatory markers. And they're usually a precursor to larger amounts of edema or exudation. Again, if you see those, it's telling you like, hey, this patient's heading down the wrong road. I need to get them into ophthalmology right away so they can get those anti-VEGF injections. So those are just two of the things I'll talk about at my lecture that are going to go over diabetes. Now, there are other categories, like I said, AMD, inflammatory things, infectious things, even rare inherited things. These are all things that are going to be talked about during the lecture.
So which retinal OCT biomarkers do you believe that every optometrist should be able to confidently identify?
I'd probably focus on the two big diseases that we tend to see as optometrists, and that'd be diabetes, like I just mentioned, and the other one would be macular degeneration. So with AMD, we always worry, hey, does the patient have dry or wet? And if they have dry, do they have large amounts of geographic atrophy? And if they have dry, are they possibly going to convert to the wet form? So things I would look for in these patients, one of them again is going to be hyperreflective foci. These basically represent RPE tissue that has migrated up into maybe some of the more superficial outer retinal layers, or maybe even into the inner retinal layers. When you see these hyperreflective foci sitting on top of a drusen, that's an indication that that spot right there that you're looking at might be a precursor to future GA or future GA formation. So again, when you see that, you got to follow these patients maybe a little bit closer. Another thing you might want to consider is reticular pseudodrusen. So we know that the classic or hallmark sign in macular degeneration is drusen, right? That's usually forms in between RP and Brooks. In this case, reticular pseudodrusen form on top of the RPE. And the way I teach it to my students and the way I think of it, it almost looks like little hills or little mountain peaks that kind of stick out or look like little daggers that are going into the outer retina. If you see these in a patient who has AMD, or you're suspecting that you see these in a patient with AMD, again, it's a precursor that that patient's going to progress a little bit faster and has a higher chance of converting into more advanced stages of AMD. Again, these are things that are easily picked up on OCT, easily detectable in OCT. Again, you just have to see it a couple of times just to know what it is. and then you're good going forward.
So, how are advances in OCT technology specifically changing our ability to detect retinal disease earlier?
It's a game changer. I remember when I went to school, OCT was TD or time domain. Now you're thinking to yourself, what's time domain OCT? Just imagine an 8 pixel like a Nintendo, the original Nintendo from back in the day. That's what the scans kind of look like. So you couldn't make out real detail at that point. From there, we've advanced to spectral domain OCT, which is pretty much the standard that we use in most clinics these days. There is a more, I guess, higher resolution one called SSOCT, the swept source. That one hasn't really made it headway into a lot of the clinics that we have, but that one's just as good. And the biggest thing I think that we're doing now is we're taking OCT. We've always focused on the retina, right? When we look in the back of the eye, we think retina, retina, retina. But we should also realize that the OCT can image the choroid as well. And so a lot of the new OCTs have a built-in capability called enhanced depth imaging or EDI OCT. Just by clicking a couple of buttons or a checkbox on your OCT, you not only image the retina, but now you're getting deeper into the choroid. And we know that a lot of choroidal abnormalities drive retinal disease, right? So again, if you can image both and get a good idea of what's going on in both layers of the posterior segment, the retina and the choroid respectively, you have a better idea of what's going on in terms of your diagnosis, your pathology, and what you need to do going forward. So again, the advances are just moving forward day by day. And I can't imagine myself doing a retina clinic or seeing a retina patient without OCT. It's basically a standard or a tool that we all need to be using.
So, if you could highlight one OCT biomarker that has the potential to change patient outcomes when you identify that biomarker early, which would you say that would be and why?
You know what? I don't think I can pinpoint just one biomarker because I think each one's cool in its own way, right? So I don't think there's one that just absolutely stands out. It just depends on the type of clinic and the type of patients you see. So again, if you have a diabetic clinic, you should focus on patients, again, who are going to present with this diabetic disease. Focus on the drill, focus on, again, the cystic pockets that I'll be mentioning, focus on those hyperreflective foci. If it's AMD, again, look for hyperreflective foci, look for reticular pseudodrusen. If you can remember maybe just five or six, honestly, from the lecture, you're probably good going forward. Everything after that is basically icing on the cake.
Anything else from the talk that we didn't touch on that you'd like to touch on?
The talk, again, has a lot of clinical imaging, a lot of cases, and I feel like that's a great way to, take away anything that I'll be teaching, and you can apply to your own clinics at that point. There's basic discussions on pathophys, but at this point, it's just like, what's important about this lecture? What can I take away? What can I put into my own practice? And that's what I'll be focusing on with the lecture.